Alright, welcome back, and in this lecture we're going to focus a little bit on Chapter 9, which is an introduction to the wrist and the hand, and today we're going to focus mainly on the radiocarpal joint. So let's get started. This picture you can see a nice distribution of the bones within the radiocarpal hand. So this is the thumb here, we're going to call that number 1, index 2, middle finger 3, ring finger 4, and pinky is number 5 in terms of the ordering of that. So you can see here that you have the radius here, and you have the ulna there as they meet these three bones, the scaphoid, the lunate, and the triquetrum. So those three make the complex. Now there's also this other structure, which we're going to spend a little bit of time in here, called the TFCC, and that's going to be right in there, but I'll show you some more pictures of that on the next slide. The question here is, distal radius is considered to be biconcave. So what does that mean to be biconcave? So I just want to zoom in a little bit here. Now for the concavity here, you can see that it's not super pronounced, but it is somewhat concave here and here to allow for these convex bones here, scaphoid and the lunate there. So this is going to be considered convex moving on a concave or a biconcave, which is going to follow the opposite roll and glide pattern as we do joint mobs and other joint play assessment. And what's interesting to look at, I'll zoom in here and so you can see here, you have the radius and ulna, but as you can tell, there's this space right here. It's almost like, whoa, shouldn't there be another bone there? Shouldn't the ulna extend further? But what is there? And that's what we talked about before, the TFCC, which is essentially the disc within the supportive structure, the fibrocartilaginous structure that supports and cushions this area within here. So let's look into that a little bit further. So here's a better picture of the TFCC. You'll see that it's not exactly a disc as in the intervertebral disc where it's this nice oval shaped structure. There's really a lot more parts to it. There's the disc part right here, but as you can see here, there are the volar or palmar can be used interchangeably with that radial ulnar ligament and dorsal radial ulnar ligaments there and there. You can see you have another ulno-lunate ligament connecting the ulna into the lunate, and you have this other structure here. So really, when you look at this, one way to think about this is you have the radius, and think about this TFCC almost as an extension of the radius to bridge the radius with the carpal bones and to cushion in that area here. But this is a nice visual to look at the TFCC and see how it's triangular in shape. But it does help to absorb shock, and it helps to absorb some of the load with that. However, we'll talk about this on I think the next slide, is that still most of the force, about 80% of the force with compression, is going to be going through the distal radius, whereas only about 20% is going to be going through the TFCC. So there you go. So continuing to talk about compressive loads and talking about closed kinematic chain, because generally the wrist and the hand are open chain activities, but there are times when there is pushing involved, whether it's pushing against the floor, pushing against the armrest to get up, pushing an object forward, pushing against a wall, or pushing a person, or whatever the push is. Sometimes there is this compressive load going through the hand, and we know often the hand is in an extended position, which is going to be more closed pack position. And so how is the force distributed from the hand along the carpals to the other forearm bones? And so basically we have this ratio where the majority of the weight, and it's kind of representative of what the bones are looking like, you have about 80% of the weight and the force going through the radius right there, and then you have the remaining 20% going through the TFCC and into the ulna, although some of that weight may be distributed slightly to the side of the radius there as well. And then as the weight gets distributed to the radius, you can see you have your scaphoid here and your lunate. Now the scaphoid is bigger, so that's going to really take about 60% of the 80%, and the lunate's going to take about 40% of that. And the big point, why am I mentioning that, is that of the bones within the carpal, the scaphoid in this proximal row of carpal bones is ultimately going to take up the majority of the load, or almost half, I should say, of the load of the compressive load. So it's a very critical bone that we examine, and when that bone gets compromised, there can be some serious consequences to that. Additionally, even though the TFCC only takes 20% of the load there, where it doesn't seem a lot, it is this disc type structure, so it's not as dense as bone, and it's not meant to absorb the loads that bone can absorb, because it's much denser and has stiffer, stronger tissue than that. So for that reason, that disc can be compromised and can be easily triggered with excessive loads. And when that happens, sometimes the individual ends up putting more load and compensating more load through the radius over here whenever their TFCC can't handle that load. And we'll go through some examples of that. Okay, well, we made it for a few slides, but now it's time to enter the cheesy joke portion of the online lecture. And this is one, not everyone's going to like this one, but that's why it's a cheesy joke. So there's two fish in a tank, and the one fish goes to the other fish, "Hey, how the heck do you drive this thing?" And yeah, that's your joke. So if you don't get that, that's okay. Just let it go. It'll go bye-bye, and then we'll talk more about open and closed pack positions just a little bit on this slide. So open pack position, what is the open pack position for the radial-carpal joint? It's going to be neutral between wrist extension and flexion, but then there's a slight ulnar deviation. And it makes sense. If you look at the shape of these bones, you could see how, because of the concavity of the radius and how the distal portion of the radius extends further, there is a slight ulnar deviation to that to keep the bone surfaces apart and not approximated. So then what is closed packed position? Closed pack is going to be the position where you have generally the maximum amount of bony congruency and fit. And so what would make these bones, these joint surfaces between the proximal carpal row and the radius and the ulna more compact? And that would be an extension. So I know this is only a two-dimensional picture, but if you can imagine extending the wrist and then adding to the radial deviation. So extension plus radial deviation is going to give you your closed pack position. So if you're thinking about almost when you're in that plank position or a push-up position at the top, your wrist is extended and it's radially deviated depending on how you position that, that would be a closed pack position. A very stable position, but also one where the joint surfaces have a lot of contact with each other. We tend not to test everything in that position, although we might put the wrist into extension if we want to test the TFC and maximally compress that area. So then the last concept we'll cover in this online lecture is the ulnar variance. And what is that referring to? Well, you see, in normal alignment, how are the distal ends of the radius and the ulna positioned? You can see roughly there's pretty even. The radius on this most radial portion or lateral portion, it does extend a little bit further, but for the most part the radius and the ulnar are equally balanced in there. However, if there's some type of variance or unevenness with that, you could see the difference here. So this is an example of, my marker right here, this would be a negative ulnar variance, saying that the radius is extending a lot further, and then here you have the ulna down here, so there's that separation, that variance, and that is ulnar negative. Or if you'd like to think of it as having a short ulna or a long radius, that is considered ulnar negative variance. One of the complications with this is the weight bearing is going to be different. So compared to, look how the weight may be distributed normally, and then what is the difference with load and weight there, because there's more of a distribution in this portion. You can see that it's going to create an imbalance with how things are distributed. So one of the things that may affect is going to be let me get my highlighter out here, is the lunate, which is in green right there. And you may get something, the patient may get something called avascular necrosis. Sometimes we abbreviate that, AVN. And you can see here in the picture, this lunate right here is a lot darker in color. Well, now I colored it green, so it's not really darker, but it was this black as opposed to white in these other bones right there, which is what you're missing. And whenever you have this occur, this avascular necrosis, we call that Kienbock's. So let me type this in here. Alright, so I got that typed in here. Kienbock's disease is what may occur with that. So you may be thinking, so what's the treatment or the correction of that? Part of that is going to be more of a structural alignment, in that if you have this situation here with Kienbock's, then what can you do to redistribute the forces? So you could basically lengthen the ulna, which is the smaller bone, so less trauma to do that, or you could shorten the radius to make that even, but some type of surgical correction, and that might involve some type of open reduction internal fixation, screws or pins, rods placed within that, or it might not, depending on the severity. But that is a complication with the ulnar negative variance. On the next slide, let's look at the opposite, ulnar positive variance. So on this picture, let me zoom in a little bit, you could see that the ulna is moved up much further, so that almost it's even with the radius here. The radius still extends here, but you can see in this picture the ulna is much further up than in the last picture. So you might be thinking, well, what does that do? Well, you notice this space in there, and we know what would be in there, that TFCC, and in that TFCC, if you have the ulna pushing there, and as weight is bared through the hand, you have this compression. So you might get this thinning of the TFCC. It might become thinner, it might become compromised in some other way, it might have uneven distribution through it, but it's definitely going to add extra load to the TFCC. And remember, the TFCC is only typically able to handle, or is supposed to, about 20% of the load. So now you're increasing this. Although you're unloading this, you're increasing the load to this portion. So with that, I'll zoom over here. So you are getting changes within the TFCC. You will sometimes see it called TFC only for triangular cartilage complex, but usually TFCC tends to be more commonly. Can get impinged, there could be pain associated with that. That is ulnar variance. So you might be wondering, well, how does that happen? So it's something we talked about in class. Remember before, let me highlight this. So you got this foosh, this fall on the outstretched hand. Sometimes that happens in a closed pack position where the hand is extended, maybe radially deviated, maybe not, but you have a radial fracture. This typical, we'll talk about what that's called later in the presentation and in class. But if you have a radial fracture and a fouche, what may happen is that the length of the radius may become compromised, so that essentially you may have a shortened radius. And this may depend on the time that it happens. If it happens during the growing years and if it affects the epiphyseal plate, then it can be significantly compromised. But even as an adult, you can have a break in the bone, and then it can create a reduction in the overall length of the radius, even just by a centimeter or two, would be some significant load differences for these joints, and that would be enough to give you this positive ulnar variance. And there might be a surgical procedure needed for that. It all depends on what happens with that, but there certainly could be a problem that presents either at the TFC or other structures, and that's the overall visual for that. That's the end of this one. We'll talk about more information on class in this and talk about some of the ligamentous structures next. Thank you.